Assalamu alaikum. I am Dr. Bushra Rooj, PGRT Pediatrics. Today I am going to start a series of lecture on pediatrics, diseases and disorders. So first of all, I am starting with digestive system, its clinical manifestations. Let's start with normal digestive tract phenomena. As we all know, gastrointestinal function varies with maturity. What is a physiological event in a newborn infant might be a pathological symptom at an older age. In intrauterine life, a fetus can swallow amniotic fluid as early as 12 weeks of gestation, but nutritive sucking in neonates first develops at about 34 weeks of gestation. As initially the infant in intrauterine life can swallow amniotic fluid followed by nutritive sucking which at birth presents as the sucking reflex, and the infant can suck blood from the nipple. So these all are developmental changes are due to the developmental changes of oropharyngeal movements, which is the result of oropharyngeal muscles maturity. As initially the infant in the first few months of life, the infant can only swallow liquids as the milk, followed by initiation of solid swallowing usually by the 6 months of life. So if our infant cannot swallow solid during the first 6 months of life, so it is a normal physiological phenomena but not a disease or disorder. The maturity of oropharyngeal movements of the muscles of tongue and pharynx, they all are the normal physiological events of maturity, the normal physiological events in the development of an infant. During initial months, the tongue thrust is upward and outward to express milk from the nipple to swallow it, followed by the tongue starts backward motion, which results in propelling the solids towards the esophageal inlet, helping the infant to swallow solids. Similarly, there is a transition in nutritive demands of the infant, as by the first initial months of age, infants appear to show preferences for sweet and salty foods. Infants' interest in solids increases at approximately 4 months of age. It is due to the maturity of oropharyngeal muscular growth. The recommendation to begin solids at 6 months of age is based on nutritional and cultural concepts rather than maturity of the swallowing processes. So, as long as the nutritive demands of the infant, they are grown up, the infant starts swallowing solids. Burping is a simple phenomena usually done by parents. It is to encourage, to prevent the gaseous distension of the stomach. Let's discuss some anatomic variations of a newborn infant which needs no appropriate treatment or any specific management, as they are normal. They don't interfere with the normal physiological processes of the infant, right? So it includes a short lingual frenulum, which is commonly called tongue tie. Usually parents present with their baby for the tongue tie. They are worrisome, but we have to counsel them that it rarely interferes with nursing, bottle feeding, eating or speech. Generally, it requires no treatment. Surface furrowing of the tongue, a geographic or scrotal tongue, is usually a normal finding. So we have to counsel the parents who may be concerned about whether their child have some oral lesions or candidiasis, etc. So we will counsel them after examining the child and after ruling out some infectious causes. A bifid uvula may be isolated or associated with a submucous cleft of the soft palate. Regurgitation, the result of gastroesophageal reflux, occurs commonly in the first years of life. Effortless regurgitation can dribble out, often in infant's mouth, but also may be forceful. Many parents bring their baby with a complaint that he vomits out frequently. Sometimes the vomitus is small, sometimes it is large. So, if we receive some infant like that, we will examine the patient. Right, first we will take a history about the volume of the regurgitation. Which should be usually in a regurgitation, the volume of the vomit out milk. So it should be 15 to 30 ml, but occasionally it can be larger. Most often the infant remains unhappy. So we have to actually distinguish between the vomiting due to some pathological event or regurgitation, which is a normal physiological phenomena. We will examine the baby. The baby is usually happy. He is having a normal growth parameters. The anthropometric measurements are normal, appropriate for age. Okay, so there may be a complaint that after an episode of regurgitation the baby feel hungry, but it's okay. We will counsel the parents. We will ask the parents about the frequency of the regurgitation. The episodes can occur from 1 to several times per day. Regurgitation gradually resolves itself in 80% of the infants by 6 months of age and in 90% by 12 months. So, is the regurgitation worrisome? If complications develop or regurgitation persists, then GERD, that is gastroesophageal reflux, is considered pathological rather than merely developmental and deserves further evaluation and treatment. So what are the complications of regurgitation? The complications of regurgitation are failure to thrive, pulmonary diseases, recurrent apneic or aspiration pneumonitis, and esophagitis with its sequelae. So we will take proper history of the patient, right? If there is history of such complications or so we will further rule out the patient for GERD. But if there are no complications, we will just counsel the parents regarding the physiological aspect of regurgitation. To sum up, if the child presents with history of vomiting, so we will rule out the pathological causes right on the basis of history and clinical examination, and then counsel the parents regarding the physiological aspect of regurgitation. Right. So infants and young children may be allergic eaters, right? This may be a worry to parents. Usually a toddler might eat insatiably or refuse to consume food during a meal. It's a very common complaint of parents that they think that their kid is not getting enough food. So first, right, they can complain that whatever they give their child, they just refuse it. Okay, infancy and adolescence are periods of rapid growth. High nutrient requirements for growth may be associated with voracious appetites. The reduced appetite of toddlers and preschool children is often a worry to parents who are used to the relatively greater dietary intake during infancy. So the parents are worried about their children that during the infancy they were very much healthy, they took the feed properly, but now they refuse everything. This is a very common complaint of a parent. So what to do? We should encourage the parents to view nutritional intake over several days and not to be overly concerned about individual meals. Demonstration of age appropriate growth on a growth curve is reassuring. Right, so we will examine the patient clinically, we will plot their height and weight on percentile charts, right, and if it is age appropriate, so we will counsel the parents regarding the eating habits, and actually we will counsel the parents regarding the diet of a child, like how much maximum calorie requirements are necessary for a child at this age group, which are different with each age group, right. We will counsel the parents about that. It is not necessary to eat enormous amount of food, right, it is not necessary, but it should be nutritive and it should have enough calories. So we will counsel the parents regarding the diet of the child, and it is not a pathological event, it is a physiological phenomena. Many parents bring their child or infant with the complaints of different variety or different frequency or different colors of stool. The parents are so much concerned about the stools of the children, or especially infants, and especially the first month of life, right. So we have to check the stool. Okay, the parents may be complaining about the frequency, the number of the stools per day. They may complain about the color, they may be very much concerned about the color of the stool, right. That is, yeah, consistency of the stool, which can vary greatly in the same infant and between infants of similar age without apparent explanation, right. Like exclusively breastfed infant, sometimes he passes 7 stools per day, or sometimes he don't pass any stool for 1 week to 10 days, but still when we examine the patient, so he is physiologically normal and happy, right. So the parents may there are different variety and colors of stool which reveals different phenomena, different events behind it. Coming to the stool's color, so initially the earliest stools after birth consist of meconium, which is a dark viscous material that is normally passed within the first 48 hours of life, right. Followed by the green brown transition stools, often containing curds, and after 4 to 5 days. With the onset of feeding, meconium is replaced by yellow brown milk stools. So these all are normal variations in colors. If the stool is green, so let's discuss about this. The stool may be green. It is not usually a cause for concern, right. Okay, it can be due to some medication, so we will take a history a little bit about medications. If the child is taking some medication, we will counsel the parents. It is normally when they will stop the medicine, the color of the stool will be changed. Yeah, if the color of stool is red, so it seeks medical advice, because usually it is due to blood in the stool, which is never physiological, right. Yellow stool, it is normal in breastfed babies. Brown or orange, also it is normal in formula fed babies. White stool, yeah, it needs medical advice, because it may be a possible sign of liver issues like in biliary atresia. Okay, black stools, they are normal in newborns under the first 7 days of life. Okay, it seeks medical advice for older babies. which may indicate internal bleeding. The color of stool has little significance except for the presence of blood or absence of bilirubin products, which results in the white gray stool rather than yellow brown. Okay, some parents may be some parents some parents may be of very much concerned about the presence of vegetable matter in the stool, such as peas or corns. So we have to counsel them that it is due to ingestion of solids, and it is normal and suggests poor chewing and not the malabsorption. Stool frequency, it is extremely variable in normal infants and can vary from none to 7 per day. Yeah, breastfed infants, as we discussed earlier, can have frequent small loose stools, early transitional stools, okay, and then after 2 to 3 weeks they can have very infrequent soft stools. So some nursing infants might not pass any stool for 1 to 2 weeks and then have a normal soft bowel movements, as we discussed it earlier. Okay, so let's discuss a little about toddlers diarrhea. Okay, so a pattern of intermittent loose stools known as toddler's diarrhea. It occurs usually between first to third year of age. These otherwise healthy growing children often drink excessive carbohydrate containing beverages, which is very common in our society, that the children, they consume the packed juice, okay, in a enormous amount usually. So it leads to toddlers diarrhea. It leads to increase in the frequency of their stool, but otherwise the child is active, healthy and alert. So the stool typically occurs during the day and not overnight. The volume of the fluid intake is often excessive, limiting sugar and unabsorbable carbohydrate containing beverages and increasing fat in the diet can often lead to resolution of the pattern of loose stool. So we will counsel the parents about limiting the packed juices, and they should replace it with fresh juices, yeah, but in a normal quantity, not so much. Okay, some parents may be very much concerned about the protuberant abdomen of their children, and especially in early childhood, many kids present with a protuberant abdomen. So again, we will take a detailed history, we will examine the child. Our clinical examination should be effective enough. We should be very well in examining the child, and we should know the physiological aspects of general physical examination. We should have enough knowledge regarding the palpable viscera of abdomen, regarding the normal physiological presentation of a child, right? So usually it results from the combination of weak abdominal musculature, relatively a large abdominal organs and lordotic stance. So we will examine the child. Let's discuss about some normal findings of examination. So in the first year of life, it is very common to palpate the liver. Okay, let me discuss about examination. Let me explain about the general physical examination a bit. So we will start the examination from top to bottom, right? First we will examine the abdomen superficially. We will palpate the abdomen, right? It should be soft, non-tender, right? Coming to the deep examination, we will see We will examine for the liver first. We will palpate the liver. Usually it is 1 to 2 centimeter palpable below the right costal margin in the first 12 years of life, right? The normal liver is soft in consistency and percusses to normal size for age, right? A renal lobe is a thin projection of the right lobe of the liver that may be palpated low in the right lateral abdomen. A soft spleen tip might also be palpable as a normal finding. In thin young children, the vertebral column is easily palpable and an overlying structure may be mistaken for a mass. Pulsation of the aorta can be appreciated in the epigastrium, right? Normal stool can often be palpated in the left lower quadrant in the descending or sigmoid colon. The gut sounds, usually they are normal, right? So again we will counsel the parents for not to be so much worried about the protuberant abdomen and continue with the normal physiological, continue their life with the normal physiological activities and encourage them for healthy activities of a child. Blood loss. Coming to the blood loss from the gastrointestinal tract is either from the mouth with a vomitus or it is from the stool, right? So it is never normal. Blood loss from the gastrointestinal tract is never normal, but swallowed blood may be misinterpreted as gastrointestinal bleeding, as in a newborn baby, right? So maternal blood may be ingested at the time of birth or later by a nursing infant. If there is bleeding near the mother's nipple, the baby can swallow during feeding, and then maybe he regurgitate it, or maybe with a stool he may pass the dark black stool, or maybe he regurgitate with the fresh blood. So it can mistakenly be considered as a blood loss from the GI tract of the baby, but it is the swallowed maternal blood. Nasal or oropharyngeal bleeding is occasionally mistaken for gastrointestinal bleeding. So we have to examine for the other systems also. Okay, in a childhood, usually in the first years, in early childhood, the children usually consumes the candies and right, as you know, the candies and juices, they have the red dyes in food, so they can turn the stool red, but do not produce a positive test result for occult blood. So we will go for a test stool examination for occult blood, right? And then we will counsel the parents regarding they should avoid the artificial food colors having things in diet, foods in diet. Okay, coming to the jaundice is a normal physiological finding from the second day of life, maximally up till the 10th day of life. It is never physiological beyond this period, except for the breastfeed jaundice, which can be as much prolonged up till the 3rd week of life, right? So it is very common in neonates, especially among the premature infants, and usually results from the inability of an immature liver to conjugate bilirubin, leading to an elevated indirect component, right? So as we discussed about the breast milk jaundice, it is usually the persistence of elevation of indirect bilirubin levels in a nursing infant, which may be a result of breast milk jaundice, which is usually a benign entity in full-term infants, and it usually resolves by its own up till the 3rd week of life, with stopping with discouraging breastfeed for not more than 1 week. Okay, the degree of jaundice does not always directly correlate with serum bilirubin levels. Sometimes the parents are so much concerned regarding the palarness of the baby, so we must go for a lab investigation regarding the bilirubin levels. An elevated total serum bilirubin warrants closer examination, right? Fractionation of bilirubin into direct and indirect, and ongoing surveillance. An elevated direct bilirubin is not normal. It is never normal even in the first 10 days of life. It is never normal, right? And it suggests a liver disease. Although in infants it may be a result of extra hepatic infection like urinary tract infections. We must have to evaluate the child for other diseases. It may be a hepatic or it may be extra hepatic, but we must evaluate the elevation of direct bilirubin, right, in a newborn infant. The direct bilirubin fraction should account for no more than 15 to 20% of the total serum bilirubin, right? Elevations in direct bilirubin levels can follow indirect hyperbilirubinemia as the liver converts excessive indirect to direct bilirubin. Let me tell you one thing, that jaundice is a very detailed topic and we will discuss later on when we will be discussing the pathological events of digestive tract in terms of its pathophysiology, in terms of its causes, right, its management, prognosis and outcome, right? So right now we are just discussing the normal physiological jaundice. Okay, so let me tell you a bit about indirect hyperbilirubinemia, which occurs commonly in the normal newborns, tends to tint the sclera and skin golden yellow, whereas the direct hyperbilirubinemia produces a greenish yellow hue. Atypical elevations of unconjugated bilirubin are associated with risk for encephalopathy and kernicterus. So why we will go for a lab evaluation? Because we have to, again I will be discussing these things in later on pathological events of GI tract, but as we must go for the lab evaluation of a newborn presented to us with jaundice, if he is we will check for the degree of jaundice on clinical basis, like if only the face is pale, right, on the second day of life there should be only facial pallor, right, which includes a sclera, yellowing of the sclera. On the second day usually it goes to up till the abdomen, right? On the third day the baby may be whole jaundice, and by the fourth day of life it starts resolving. But if on the first or second day if the child is clinically jaundiced up to grade 2 or grade 3, right, or he is lethargy or not taking feed properly, or there is some danger sign of illness, so we must go for lab evaluation, because we have to prevent the baby from kernicterus, right? Because the indirect bilirubin can cross the blood-brain barrier very easily and causing the CNS complications, right? And direct bilirubin cannot, but it is never physiological in the first weeks of life. So we have to evaluate excessive indirect hyperbilirubinemia to decide for possible need of phototherapy, possible need of exchange transfusion, or there may be no possible need for any treatment. We will just encourage the parents regarding the sunlight therapy at home regularly. We will counsel the parents regarding proper feeding, right, and close monitoring. So we will be discussing in detail the jaundice later on, right, in the subsequent chapters or topics. So today we discussed some physiological events of GI tract. I hope it will be beneficial for, and let me tell you, I will be uploading soon further pathological illnesses of GI tract, the pediatric disorders related to GI tract, and many more. So for more videos, please like and subscribe my channel, so that whenever I upload a new video, you get a notification regarding that. Thank you.